Welcome everyone. For those of you who don't know me, I'm Sasha Hardman, the HR Director. I've been back at the firm for 3.5 months, so some of you I do recognise. I'm delighted to welcome you here this lunchtime. This is our third Fit for Life event, so a real opportunity for us to showcase what we're doing in terms of our benefits and what we have to offer as a firm, but also an opportunity for us all to think about our own health and well-being. We've also got some people here from Circulate, the Barts charity. We've got Belinda here, who's sitting at the front, who will come up on stage in a minute. And we've got Danny and Sophie at the back there, who will be rushing around with microphones when we do the Q&A at the end. And Circulate is a charity at Barts Heart Centre, really focused on tackling heart disease. What is scary is it's still Britain's largest killer, both of men and women. And so their focus is really on how we tackle that, working with local communities and neighbours around improving education, long-term awareness and prevention. So please, if you get an opportunity either at the end to ask questions or after the event, if you want to talk to them about their charity, then please do. And so to the main event, we are very lucky that we've got Dr. Sam Mohiddin here from Barts Health Centre, Heart Centre even, who's sitting here. It is the leading, I hadn't realised this, it's the leading heart centre in the world, and he's here to talk to us about sudden cardiac arrest. Those of you who support football, and in fact even those of you who don't, I would find it surprising if you didn't hear in the news about Fabrice Muanda, who was the footballer who had a sudden cardiac arrest at Tottenham during the FA Cup match in 2012. Well, Sam here was the person who treated him and continues to treat him today. So we're very lucky to have him here to talk to us about that. I'm sure what he's got to say will be very informative and lots of food for thought. So I'm delighted to welcome you on stage, and Belinda, if you want to. And the other thing is, at the end, there'll be an opportunity to ask questions. I think Sam's going to ask you some questions as we go through. Can you please raise your hand? And then Danny and Sophie will rush around with microphones, because we're recording this for people who aren't able to make it. So we're very keen that you speak into a microphone when we've got a question. Thank you.
I'm Belinda D, and I'm Director of Development at Barts Charity. We're an independent charity with a very simple vision: extraordinary healthcare for all. We fund medical innovation, and we also fund projects that go beyond standard healthcare that have the greatest potential to change lives. With the opening of the new Barts Heart Centre, the largest specialist centre of its kind in Europe, we have a major opportunity to tackle the world's biggest cause of death today. In this country alone, cardiovascular disease kills 1 in 4 of us, and that's 160,000 people a year. And in order to reduce these numbers, Barts Charity has teamed up with the Barts Heart Centre to form Circulate, the Barts Charity Heart Health Network.
Barts Hospital was founded in 1123, so we're just coming up for our 900th birthday, and it has always had a very strong relationship with the city and city institutions. The unique position of Barts Hospital right at the heart of the city means that we're surrounded by some of the top financial institutions in the world. And what we really want as part of Circulate is to see our neighbours and colleagues in the city come to Circulate events, not come through the front door into our heart attack centre.
At the present time, if you have any sort of life-threatening cardiac event, and you're lucky enough to have that within the City of London, you will be brought directly here to the Barts Heart Centre by the ambulance, where your chances of survival are the greatest.
Okay, Daniel, how are you doing in there?
Yeah, not bad at all.
We have been able to provide this kind of world-first unique service thanks to the help of initiatives like Circulate, because it allows us to provide stuff that the NHS wouldn't normally fund. So they seed money to these initiatives, we prove that they work, and then the NHS takes them up as a standard service.
Circulate will tackle cardiovascular disease on 2 levels. Firstly, by encouraging our city neighbours to fund innovative advancements in world-leading heart care and groundbreaking research projects, whilst also fulfilling some of their CSR objectives.
So if you apply a little retroflexion there, you can see the movement, not too much, it's only a small movement.
Secondly, we will engage with all local businesses who are keen to promote employee wellbeing, with a grassroots programme of heart health activities for their staff delivered by experts from the Barts Heart Centre.
The health and well-being of our employees is important to everyone at Linklaters. I think Circulate is a sophisticated, a modern approach to tackling an obvious community need, but also more locally to us within the firm, a real opportunity to share knowledge, advice and guidance on a key issue of well-being for our people.
So this is a gentleman in his 30s. We see a lot of young people, and so people who work in the city. There is definitely evidence that stress and hard work may promote arrhythmias. They often have high profile, very intensive jobs. These sort of symptoms will stop them doing what they want to do in life.
We are very excited about Circulate. We see it as a real partnership between the hospital and the Heart Centre and businesses and the community around Barts Hospital, so that we can bring to them the benefit of some health education and making sure they understand how important heart problems are and how easy it is to really make differences to avoid them. And at the same time, to Circulate will allow us to get support from businesses towards making sure that the next few generations have an even better outcome from their heart problems.
Whether your organisation wishes to support us financially or you're simply interested in safeguarding the heart health of your employees, please get in touch with us today to find out how you can get involved in Circulate, the Barts Charity Heart Health Network.
Thank you, Sasha. My name is Sam Mohiddin, and today the topic that we've chosen is on sudden cardiac death in young people and in athletes. And my aims today really are to discuss causes of cardiac arrest in young people, particularly in athletes. We'll also touch on methods that may help us prevent these catastrophes. And then finally, at the end, perhaps discuss this also, is to talk about what we can do to get better at identifying those at risk of sudden death and, of course, at preventing sudden death. So the presentation is meant to be interactive today, so if there are burning questions, please do interrupt. And there will be moments in the presentation where I'll ask you to tell me what you think. This is quite a powerful slide, and it means an awful lot to me because of my involvement in looking after Fabrice. I get very nervous when I see this slide. But it does bring to the fore some of the very important issues to do with sudden cardiac death. On the left-hand side, Fabrice Mwamba is having a cardiac arrest. This is March the 17th, 2012 at White Hart Lane. He survived, we know that, and on the right-hand panel is an Italian football player called Pier Mario. The day before Fabrice was discharged, this happened to Pier Mario and he died. So a number of issues we will need to discuss, or we intend to discuss, and these two instances, I think, put the discussion into relief. And we'll touch on some of those in the talk. So my first question to the audience really is about what it is to have a cardiac arrest, what a cardiac arrest is. And every time I listen to a health program on television that talks about cardiology, these two terms are used interchangeably. So the first question to everyone, yes or no, put your hands up if the answer is yes. Are these two things the same? Is a cardiac arrest the same as a heart attack? Yes, hands up. No, hands up. The no's have it. A cardiac arrest, a heart attack is caused by a blockage in a coronary artery, which results in damage done to the muscle of the heart because the oxygen supply to that muscle has been interrupted. And because the muscle is damaged, a cardiac arrest can occur. And a cardiac arrest is a rhythm abnormality of the heart, which I'll try and describe here. In the top pane, we've got an ECG recording, electrocardiogram, and each of these is a heartbeat, a consecutive heartbeat, so bum, 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 bum. That's a normal sinus rhythm. Bottom panel is a cardiac arrest rhythm, and you can see the electrical activity is completely chaotic. We call that ventricular fibrillation. And what that means is every single heart muscle cell is contracting or shortening at the same time, and effectively the heart stops beating. And if you don't treat this, the individual will die, and you don't have much time before you can treat them. And in this particular instance, fortunately this cardiac arrest is happening while someone's being monitored, and a defibrillator shock here. Electrical pads have been placed on the front of the chest, successfully converting that life-threatening rhythm back into sinus rhythm. We've then got to figure out why this has happened and treat that patient so as to prevent this from happening again. So when we start then talking about causes of cardiac arrest, we've said that a heart attack caused by coronary artery disease can cause cardiac arrests. And in fact, coronary artery disease and heart attacks are the commonest causes of cardiac arrests, particularly in people over the age of 40. Structural heart disease, so the consequences of long-term hypertension, valve disease, are also common causes of cardiac arrest in people over 40. When we start thinking about younger individuals, fit people, fit athletes, the next set of conditions become much, much more important. Inflammatory heart disease, inflammation of the muscle of the heart, or myo, muscle, card, heart, itis, inflammation. Certain inherited muscle disorders, and these we call cardiomyopathy, simple heart muscle disease. There are also other disorders which are inherited, abnormalities in genes that make up the electrical system of the heart, and we call those ion channel disorders. Of course, there are many, many others. If you die, your heart will stop. It comes to a rest. But these three groups of conditions, inflammatory, inherited heart muscle, and inherited electrical disorders, are particularly important in people under the age of 35, and together they are the most important causes of sudden unexpected cardiac death in otherwise healthy people. We're going to talk about those. So, question number 2, yes or no? Does exercise increase the risk of sudden death? Hands up for yes. Hands up for no. Well, both, you're all correct. It does both. Exercise is very good for your heart, and people who exercise are much likely to live healthier, longer lives than people who don't exercise. But during the period of exercise, there is a temporary increase in risk, particularly in individuals who have an underlying heart problem, which is why we see things happen at the end of marathons. It's why we see things happening on football pitches. So we're both correct. But on balance, exercise is good for you. Question number 3, and this is important because we're talking about this particular topic, and it's important for us to understand how big an issue it is. So, how common is sudden unexpected cardiac death of the type that Fabrice had? How common is this in the UK? Hands up for 6,000 cases a year. Hands up for 600 cases a year. And 60. So the simple rule there is you go for the middle, isn't it? And you're right. It's about 600 a year. So it's not many. There are many more suicides or deaths from epilepsy in the young. And so sudden cardiac death in the young is rare. It's a catastrophe. It's an absolute catastrophe, as anyone in this room who's ever been involved in a case of sudden cardiac death knows. It has a massive effect on survivors. And that effect also is because many of the causes of sudden death are inherited. So there are other people in the families that know they may be at risk of this, but the renting or the trauma that results from these events is terrible. And so we do have a small risk. It's a small risk. It has a huge impact. And the question then for all of us to try and answer is this a big enough problem for us to seek to solve it? That's a public health question. In athletes, the risk is greater. If they have underlying heart problems, we think that the risk of them dying suddenly is about doubled. So there we're left with a small risk, well, a little bit bigger, with a potentially massive impact, as we've seen with recent cases in the press. Again, is this a big enough problem? And here, whose problem is it to solve? Is it the individual's problem, the club's problem, the sports problem, a public health problem? So these are some of the questions that need to be asked, and they're in the background. And when we talk about prevention, it's important to remember that these questions haven't been answered. So, we've said it's a rare catastrophe, and we've talked about how frequently it happens. But when we go and investigate individuals who have had sudden cardiac death, we find that many do have undiagnosed heart conditions. And for these conditions, several treatments are available. And so the question is, is there an opportunity to detect cases before the sudden cardiac death? And can we therefore prevent or reduce these events? Who do we screen? When do we screen? And is it cost effective? The next part of the talk is about just those questions. The information or the data, the evidence that we have that helps us understand how important an issue this is and what we should be looking at is actually of very poor quality when it comes so the evidence that we have is of a poor quality compared to other types of evidence that we use in medicine to make decisions. And the best evidence we have are randomized, prospective studies that give us data. And this is all retrospective data. It's based on accumulation or collecting of cases in a relatively haphazard way. And this study, which is the largest study of deaths in competitive athletes, comes out of America, covers 37 years, and the way they identified cases isn't because of some rigorous, robust reporting system, but they went through internet reports and press reports and collected cases together. So there's already quite a bit of bias in that. But of these cases, they considered about 1,000 of them were due to cardiovascular disease. In these athletes, at least a fifth of those deaths happened in the athletes while they were asleep. So the importance of exercise becomes questioned. And this is a tragic figure, isn't it? 65, 2/3 of that group were under the age of 17 when they died. That just emphasizes the catastrophic nature of these events. Only 7%, a real minority, had a pre-mortem diagnosis, and most were undiagnosed. So then went on to look at the causes of those deaths, and in a whopping third, 34%, an underlying cause was not found. But in about 2/3, there were identified causes, and most of these were those heart muscle disorders, the cardiomyopathies. And if you look at the causes that they detect, again, the heart muscle diseases predominate, but there are many different potential diagnoses in this group of people, and these are very different causes of cardiac death. And so when we will start to talk about screening and prevention and detection, it's important to remember that it's a range of disorders, not just one or two. But amongst these, the heart muscle diseases predominate, as do the disorders that affect the ion channels, the electrical disorders. And this is just making the same point, and it's bringing a number of different studies together, again telling us that if we want to screen, we should be looking at these disorders, the heart muscle disorders and the electrical abnormalities. Okay, so this slide is about the heart muscle disorders, the cardiomyopathies, and I spend my life looking after patients with these conditions. On the left-hand side here is a heart that is supposed to be a normal heart. And what you can see is the left ventricle, the right ventricle, and the two atria, and the heart's contracting. This is an MRI picture of the heart, but it could be an echo, it could be any other form of imaging. Here, you can appreciate in hypertrophic cardiomyopathy that the muscle of the heart has become much, much thicker. You can see that sort of cigar shaped in the middle. And that is a genetically determined condition where the muscle becomes extremely thick. It's quite common, it affects about 1 in 500 people. And it's probably alone the single commonest cause of sudden cardiac death in the young. So if you've heard about Mark Vivian Foe, he had this condition, and more recently David Frost's son, who died running a marathon, had been diagnosed with this condition. But there are other cardiomyopathies. There's a dilated cardiomyopathy, where the muscle of the heart becomes weaker and the heart becomes baggy. Again, it's a primary muscle disorder. And then a rarer cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, which we see rarely in this country, but it's actually very common in Italy, where it's the commonest cause of sudden death, and it's characterized by a disorder that affects the right ventricle of the heart. It's very pro-arrhythmic. It causes cardiac arrests. So, can we diagnose these by imaging the heart, and so screening can potentially detect undiagnosed conditions by imaging the heart muscle in populations who you think may be at risk. This slide is about the electrical disorders or the ion channels. The ion channels are shown graphically here. If anyone remembers their A-level biology, you have membranes around cells, and the cells, those membranes have ion channels through them that allow sodium, potassium, calcium, sodium, potassium, calcium to pass through them, and that allows excitable cells to signal things like contractility. And genetic abnormalities in these ion channels mean that the electrical patterns or activities move in an abnormal way, and that may cause an abnormality that we can detect on the ECG. There are lots of different things you can measure on an ECG, and some of these abnormalities are responsible for different parts of that ECG. So if you have an abnormality in the potassium channel, it may alter your QT interval, and you can detect people that may have a disorder that can then predispose to the abnormal cardiac rhythm. So again, in screening, because this is an important cause of sudden cardiac death, you may be able to detect undiagnosed ECGs by doing undiagnosed cases by doing an ECG. And so screening protocols have been developed in order to try and identify individuals who are at risk, and these are based on these three things. And all of us will be aware, we've all answered structured health questionnaires. In this particular instance, you're looking for evidence of symptoms of fainting, chest discomfort, and a family history of sudden cardiac death. I think that's a very powerful thing. But also these tests, an electrocardiogram and an echocardiogram, to look to see if there's any evidence of electrical abnormalities or morphological functional abnormalities of the heart muscle. And that's how screening is done. And then next question for you is, based on what you've heard already from this talk, will screening of athletes prevent sudden cardiac death? Will it prevent it all, some, or none? Hands up those that think it'll prevent all sudden cardiac death. No cardiac death. So we all agree that some cases will be prevented, and then the critical question we have next is, will it prevent enough for it to make the endeavour of screening worthwhile? And the initial data suggested yes, and this is a famous slide in my small area of cardiology that's been used to justify screening programs that are now used by the IOC, by the FA, and by many other sporting organisations. And what this slide shows is the incidence per year of sudden cardiac death in northern Italy, with the incidence between 1979 and 2003, and the solid line is sudden cardiac death in athletes. The dotted line is the background that happens in the community, so sedentary people of the same age. The red arrow represents the time that the Italian Parliament made it a law that any athlete in Italy had to have a screening ECG. And they present this data showing that following the introduction of the screening ECG, the amount of sudden cardiac death fell not just by a bit, but by 90%. Almost completely abolished this as a problem, suggesting that the screening tests can detect almost all the cases of underlying disease, and that what we do in response to that information allows us to prevent death. And that powerful message has been heard by many, and as I've said, it's used by the IOC, by the FA Academy program, by the Lawn Tennis Association, and also it's a message that we hear a lot from advocacy groups. I belong to an alternative view, which is that we have to approach this with quite a bit of caution. It's a very expensive way of detecting or preventing death, and that may sound a little bit insensitive, but there is a certain amount of public health money, and we should spend it in the most effective way of preventing death. And is this an effective way or not? I don't know. There's also the concern that it turns public events, so things that may have happened on television because it's a sporting match, may just make these hidden events, so you're moving it out of the public eye. But these are the two more important points, I think, here. There's no solid proof that this works. We've seen the Italian data, but is that data that is robust? And could it be potentially harmful? And by that I mean, by telling people they have a problem when they don't have a problem, are we actually harming them? And there's very good evidence that that can be the case. And it's the case because our tests are more like the crystal ball than they are like the tricorder of Dr. McCoy. Our tests have accuracy problems. They have false positive rates, they have false negative rates. And I think it's true, the more you spend on a test, the better answer you get. And for screening tests, we want easily used cheap tests. We're using a crystal ball here, not a tricorder. And so there are difficulties with screening. So for example, I showed this pie chart earlier on. This is the list of potential causes of sudden cardiac death. If you then look at the tests that we have, actually only about 40% of the causes, underlying causes of sudden death, are detectable by these tests. And that's because some of these conditions are either absent when you test. So, for example, one of the commoner causes of sudden death is inflammation of the heart. I can't do a test on anyone here today that tells me whether or not they'll have flu next year. So it's a little bit like that. These are unpredictable events. Some of these tests are also extremely expensive or invasive. So in order for us, for example, to detect if a patient has a congenital abnormality of the coronary arteries, we can't do that using these simple tests. The final point is also very important. An athlete's heart is itself abnormal. And many of the remodeling changes, both in the electrical system of the heart and in the muscle of the heart of an athlete, mimic these underlying heart problems. And so we often will find ourselves in situations telling people with very normal, very healthy hearts that they may have a heart problem. And that's why this can cause damage or harm. Okay, the rest of the other countries have also now developed experience in screening. And the Italian example I showed earlier is in pink, showing when the law started and what happened to the incidence of sudden death afterwards. The Israeli example is actually very instructive. And what happened in Israel is about 1993, 1994, there were a cluster of cases of sudden cardiac death, leading to a public outcry about this as a problem. And the institution, in response to that, of a law that mandated cardiac screening. And that happened where you see E. But actually, although you might look at what happens to the right of that as showing a reduction in sudden cardiac death, if you went back and looked historically, there were few cardiac deaths there. So this is a phenomenon of regression to the mean. You see some cardiac deaths, you change something, but actually the reduction in cardiac deaths has got nothing to do with what you've done. It's just the natural history. Does that make sense? How are we doing for time? So what I was going to talk about next then, in the context of these screening, there's a real emotive push and need to identify and prevent these terrible events from happening. And we've mentioned that it's at least theoretically possible, but there are problems. And I want to talk about now 3 or 4 cases of where screening has been problematic, just to illustrate the effects that getting this wrong can have. I've changed some of the details about individuals for obvious reasons. This is a mixed race, 17-year-old footballer, and we say mixed race because another difficulty with screening is that black male athletes often have cardiac abnormalities that are abnormal in any other group than black male athletes. They have ECGs and their hearts look different. And this is someone who's mixed race. He has a few symptoms. He's a bit short of breath, but of course you're short of breath when you're training. You train until you get short of breath. gets a bit dizzy when he's training, but he hasn't had breakfast that day. But these are the symptoms that we're looking for as risks. And this is a routine screening program he's in. He then has an ECG, and this is his ECG. Here, and please take my word for it, the ECG is abnormal. It's abnormal in the way that a black male athlete's ECG may be abnormal, but not a white man's ECG. Because of that, and because of the uncertainty as to whether or not this is normal or abnormal, it's a grey area. He has an MRI scan of his heart, which shows the muscle of his heart's thick. It's about 1.5 times as thick as it should be if he was doing nothing, but it's okay for a young black athlete. But still, there's a lot of emotion involved, and he stops training. He stops training and has another ECG. This time the ECG is completely normal. The thickening of the heart has gone. So we say to him, "You got it wrong. This isn't a heart problem. This problem here this is all to do with the false positive aspect of the screening. Your heart's normal, go back to training." He goes back to training. And this time his ECG again becomes abnormal, but in this instance it's unequivocally abnormal. Any cardiologist that sees this would think, there's a problem here. So he stops training. His ECG is now normal, but he's now stacking shelves in Sainsbury's rather than pursuing his career as an elite athlete. We got this wrong. This man has a normal heart. But screening told him he could have a problem, and he's lost his opportunity to pursue his career goals. This is a 16-year-old sprinter, also of mixed race. And many people that we see in London and in this country who are elite athletes are of mixed race. And it's important because of the reasons I've mentioned. This ECG is abnormal. And because of his ECG, he has other tests which are all normal, and we tell him we think he's normal, and he continues training and competing. This ECG was taken about a year later. Still abnormal, but the only difference between the two is that he's had a cardiac arrest in between these two times. Again, false negative. We got this wrong. We will get it wrong, and this resulted in quite a large law case because he wasn't diagnosed with something that our tests couldn't detect. And then two final cases here. These aren't athletes, these are young people. On the left-hand side here, this is actually the case of the person whose cardiac arrest I showed you. This is an inflammatory heart disease called acute cardiac sarcoidosis. Some of those words may be familiar to some people. It causes sudden cardiac death, or can do. And the chest x-ray at the top right there is an internal defibrillator. So that's an implanted defibrillator that's been used after we know he's at risk. This is just an example of how we diagnose it. To diagnose that condition, we have to obtain a bit of tissue by doing a cardiac biopsy. And clearly, that's not the sort of test you can use in screening. This is a sad case here of a 35-year-old man who died one day after his cardiac MRI scan was done. And he had another kind of inflammatory heart muscle condition called giant cell myocarditis. You cannot detect these by screening because they are transient disorders, not there when you look. So back to the beginning of the slide, and to make, I think, one final, really important point is that Fabrice is alive and Pierre Mario isn't. And there are many reasons why that might be the case, but one of the things that may be important is that the doctors and physiotherapists at White Hart Lane responded extremely quickly, and they provided extremely effective CPR to Fabrice. A very experienced paramedic crew was available on site, and they attended to him very, very quickly, and they took him very quickly to a cardiac centre where he received further treatment. That's what saved his life. Fabrice had been screened 4 times and nothing had been found, so this shows you how screening is a problem. Pier Mario Morosini comes from a sporting culture where every athlete gets checked several times. Again, they didn't detect his risks. And tragically, the ambulance that would have taken him to hospital had its route into the stadium blocked by a police car that had been parked over the access road. It's the exact opposite. It's tragic. So in summary, sudden death in the young and athletes is rare. It is rare. It doesn't happen very often. but it has catastrophic effects on families, communities, and the wider public. It's often caused by undiagnosed but potentially detectable heart diseases, and therefore many cases, and many other cases, however, are due to what we cannot yet understand. They're unexplained. We need to understand these, or as yet undetectable or possibly transient disease. So screening will only prevent some deaths, and the emphasis that we have on detection shouldn't diminish investment in resuscitation. That made the difference between Fabrice dying and living. And our challenges in going forward include, I guess, further research that improves our ability to diagnose and detect underlying heart conditions, and providing better management of catastrophes when they do occur. So we need more sensitive and accurate tests. I haven't talked about how we manage patients once they are diagnosed with conditions, how we prevent that cause and sudden death. But this is also very important. And if anyone in this audience wants to know how to make a difference, it's to learn CPR. If 1 in 10 of us could do CPR, we would be saving hundreds of lives, not just of young athletes, but also of older people. Imagine having a cardiac arrest at Liverpool Station and knowing that several dozen people there can do CPR, and not only can they do CPR, they know where the automatic external defibrillators are because they're in public spaces. If they don't, they can use an app that tells them where the defibrillator is, or even in some countries, an app that will call a drone that will bring them a defibrillator and call the paramedics that will take them to a specialist cardiac centre where they use new modern technology to stabilise the situation. So that's my talk. What I haven't discussed is another very important way of preventing sudden cardiac death, and that's in families that have inherited causes. You screen families then and you treat families, and I haven't really talked about what you do in people at risk, and this is a picture of Fabrice with a defibrillator implanted. That's an implantable defibrillator. I don't think it had very much to do with God, but that's my personal perspective. Thank you very much.